Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue our discussion about follicular lymphoma, this time talking all about frontline management for follicular.
Excited to get into this one. Obviously, lymphomas are my personal favorite topic, so got a lot to unpack here. Historical interludes are always good, and we're back from a good break, so really excited to get back into the swing of things.
Yeah, let's do it.
All right, guys, without further ado, let's roll that show.
You guys, I'm so excited. My camera is coming this week. I just bought an old Soviet film cinema camera, and I'm very excited to have an expensive new hobby.
So I was watching the TV show The Studio, great TV show on Apple TV. And is this a thing where you're trying to make movies, Dan, or are you trying to just get into amateur filmmaking? What's this all about?
Yeah, I've always liked still photography, and so just trying to translate that over to motion picture photography, which I can only assume is a terrible mistake to think that I could do both. But, what's old is new. I wanted to go back to, it's because of this generative AI. You have a film negative. I mean, I'm sure you could fake that too, but it just seems harder to fake. So now people will know if I take a video of something, it actually happened.
That's pretty cool. And you were also saying that you've been experimenting with lighting. Tell me more, Dan, because you know I love a good photo, a good video shot.
It's true. I didn't realize just how important it is. And it's sort of funny. It's one of those things where you don't miss it until it's gone. And I just noticed in a lot of newer releases, stuff that you see on TV, even like prestige releases, Game of Thrones, whatever else, don't sue us, HBO. Everything's flat. It's just like kind of dim or kind of bright. There's no drama to it. And I was just watching older movies, older TV shows recently, and it's just so different. So I wanted to learn what that is. And so as if I needed a more expensive hobby than shooting video on film, I've also decided to learn a little bit more about lighting.
The wonderful world of Dan. So I'll start off with the case. We have a 75-year-old female who presents to clinic for evaluation of likely follicular lymphoma. She had asymptomatic enlarging right cervical adenopathy measuring 2 centimeters and underwent an evaluation by ENT. She had an FNA performed in clinic, which was notable for a monotypic CD10 positive B-cell population that was concerning for a small B-cell lymphoma. On history, she has felt well without any complaints. Exam is notable for 2 palpable right cervical lymph nodes and otherwise unremarkable. So can one of you recap the workup for follicular lymphoma?
Absolutely. So definitely check out our intro episode of this whole series for a refresher on FNA versus core versus excisional biopsy. In this case, we need more tissue to establish a diagnosis. She would ideally get an excisional biopsy, as the classification of follicular lymphoma really requires an assessment of the underlying nodal architecture to rule out any parts that might have transformed or have higher risk features. You got to remember that not all locations are amenable to excisional biopsy, and core biopsy can still be adequate in folks with a low symptom burden and nodes in kind of hard to reach places. You'd want to obtain a PET CT for staging and to assess the baseline avidity of her adenopathy. That's the SUV uptake that we talk about, how we grade how avid a node is. A lack of a high SUV uptake, so SUVs less than 10, favors a more indolent follicular lymphoma, and it makes transformation just less likely. I do want to point out that this SUV rule is by no means perfect, and we always recommend an excisional biopsy when feasible, but it can aid in clinical decision-making. Some transformed lymphomas will have SUVs around 9, some classical follicular lymphomas will have SUVs above 10. Again, it's a little bit fraught to just rely on that. If there's an SUV above 20, certainly that is very concerning for large cell transformation. And if there's an SUV around 4 or 5, it's more consistent with follicular lymphoma. And if a core biopsy was already done, you can kind of stop there. So it helps guide that triaging a little bit. It's also always important to get a baseline CBC with differential, LDH, those tumor lysis syndrome labs, hepatitis B panel, anticipating that we're going to need CD20-directed therapy at some point, and HIV testing. Although bone marrow biopsy can be prognostic in some of these patients, it's not mandatory for treatment, and it can lead to an unnecessary procedure that wouldn't really change your management in most cases, with a few exceptions. The first exception is to confirm stage 1 disease when you're planning for radiation as a possible curative measure. The second is to determine if cytopenias are related to the burden of follicular lymphoma or if there's an alternate etiology to explain somebody who's cytopenic and has a follicular diagnosis. Also, if a patient has multiple nodal sites, a bone marrow biopsy should not be performed generally, and we'll go through some of the trial data on why this is the case later on in this episode.
So she underwent excisional biopsy of her right cervical adenopathy as Dan had recommended, which showed a CD10 positive monotypic small B-cell population, and this was consistent with classic follicular lymphoma. PET-CT showed isolated right cervical adenopathy without other sites of disease, and that had an SEV uptake of 8, so it kind of really fit with this diagnosis of classic follicular lymphoma. Her labs were all unremarkable. She's now in clinic. She's pretty anxious about her new diagnosis of cancer. This happens all the time when we see these patients, and wants to know the next steps in management. How do we treat localized stage 1 follicular lymphoma?
Yeah, we really do see this all the time, so it's important to go through this with your patients to help ease their anxiety. Just to reiterate, we've said this before, but we don't use grades 1, 2, 3A, 3B in follicular lymphoma, but instead we use classic follicular lymphoma for grades 1 to 3A and follicular large B-cell lymphoma for the former grade 3B. And this was done because 3B would be treated with more intensive treatments like R-CHOP, whereas grades 1 to 3A all behave similarly and are treated with a less intensive approach when treatment is indicated. So for stage 1 follicular lymphoma, we have 2 options. Observation, assuming that the patient does not meet the Guelph criteria or the BNLI criteria for treatment, and we'll talk about this very soon, so don't worry. And so observation is one option, and the other option is radiation. When we counsel these patients, it's important to note that there's no evidence for improved overall survival with radiation therapy in this setting as opposed to observation. The benefit of radiation, though, is that it could spare patients from needing chemotherapy in the future and provide a durable remission, and ultimately also giving them less anxiety surrounding having a cancer that is just being, quote, watched. Another more obvious situation in which treatment would be favored is if it is causing local symptoms to the patient. So, some sort of mass effect from the swelling in the lymph node. Radiation for follicular lymphoma is often well tolerated and a reasonable approach for these cases. And if you were to pursue radiation therapy for your patient, some would argue that a bone marrow biopsy should be obtained because if it's positive, radiation would probably provide durable local control, but it wouldn't actually cure the underlying issue, which, in this case would be a more systemic disease. So guys, before we move into the data regarding observation versus radiation for early stage follicular lymphoma, why don't we talk a little bit about the historical context? It's time to put on our history hats. I'm going to pass it over to our resident historian, Vivek. Can you walk us through some of this information?
Yeah, I was going to start in the 1950s, but I'm actually going to skip that just in the interest of time so less people fall asleep. So let's actually start up in the 1970s. So by the 70s, we knew there was this entity of follicular lymphoma, also previously called nodular lymphoma. And at that time point, some patients who underwent multiple biopsies at different sites had different histological features on each specimen. For example, one site might have a follicular growth pattern, and another site might have diffuse large cells. And it was often patients with these diffuse large cells on biopsy that had rapid progression of adenopathy that was previously relatively stable prior, and they became very symptomatic more quickly. This established the idea that this underlying follicular lymphoma that we can watch in some cases can transform into an aggressive large B-cell lymphoma, and that the biopsy site can be really informative. This is why in the modern day we get that PET-CT, because we want to biopsy the most avid site. That's why we kind of harped on those SUVs. This was really discovered in the 70s. So now we have these patients, and the question was, well, what if you just let it sit there? Are they all going to just transform into this aggressive lymphoma? Who should we be treating? Are there ways to mitigate that? In 1984, there was a physician, Dr. Saul Rosenberg from Stanford, who reported an observational study of patients treated there. And they were all observed, really, at the beginning. From 1961 to 1982 was the cohort that was included. 111 patients, and 82% of them were not treated at initial diagnosis. The median overall survival in those not treated was 11 years, and some patients lived over 20 years. So this kind of led people to think and lymphoma doctors to know that, hey, you know what? We don't have to treat everybody early. Not everybody is going to transform into an aggressive large B-cell lymphoma. Some of these patients can behave a little bit more indolently. And if we think about patients diagnosed in their 70s and 80s, their life expectancy may be shorter than the time they would need lymphoma therapy if they're having such durable overall survivals. There's a follow-up study from a Stanford cohort published in the JCO in 2004. And again, we'll link all these things into our show notes, so definitely check these out. It included 43 patients who were all observed initially, and it showed that roughly 60% of patients didn't need treatment at 7 years. So there's a percentage of patients that need treatment. Dan described this in our previous episode, and there's a percentage of patients that just never need treatment. As a brief aside to this, back in the day, and we're talking 70s and 80s, the thought was, how do we prevent aggressive large cell lymphoma? There was that concern that should we treat early? And there was a study that actually compared observation versus a crazy regimen called ProMACE MOP with a ton of letters in it and a lot of chemo, followed by total nodal irradiation. This is observation versus crazy intense sledgehammer therapy, and there was no difference in overall survival. Over 50% of patients in watchful waiting never needed treatment, and that really should let everyone here understand that about half of patients with follicular lymphoma are going to do fine, the other half are going to need some treatments, and there's a subset that are not going to do well, and it's impossible to know who's who. There were different prognostic scores. One of them is called FLIPI. We talked about the IPI score in large cell lymphoma. But the FLIPI score doesn't really pan out as well as the IPI score. This was developed pre-Rituxan and often not used in the modern day. There was an updated score actually presented at EHA like 2 days ago at the time of this recording, where we know now that bone marrow biopsy positivity and an elevated beta-2 microglobulin can be prognostic, but it's not ready for prime time to make any sort of treatment decisions. That's why we're not advocating to get all of these testing before. So we don't have a good prognostic score. We're not saying definitely get a bone marrow biopsy in patients because it's really not going to change your management. So then, now that we have these patients, historically, the question comes, who do you need to treat? And there are 2 pivotal studies that looked at this question. The most cited that we all talk about was the pivotal GELF study, GELF, the GELF study, published in JCO in 1997. GELF is an acronym for a cooperative group in France. I don't want to pronounce it because I'll definitely mess it up, and I don't want to let our French listeners down. This included follicular lymphoma patients with low tumor burden, and patients with the following features were excluded because they were felt to just need treatment, right? Because this is a question of observation versus treatment. Any tumor greater than 7 centimeter, 3 nodes and 3 different nodal groups, all greater than 3 centimeters, symptomatic splenomegaly, organ compression, malignant ascites or effusion, B symptoms, elevated LDH, or cytopenias from their follicular lymphoma, all those patients were excluded. And that exclusion criteria is now known as the GELF criteria. And so the GELF criteria is when we say, hey, we need to treat them because they weren't included in this study, that was observation versus prednisolone or interferon. So that was the randomization of the study. No difference in overall survival. So observation, no different than prednisolone. I know we all haven't heard about that. And interferon, no difference in survival. So that led to that. There was another pivotal study published by the British Lymphoma Group. And in this study, it included not only low tumor burden follicular lymphoma patients, but advanced stage follicular lymphoma patients. We're talking about nodes above and below the diaphragm. Study was published in Lancet 2003. It was run by the BNLI group, or the British Lymphoma National Investigation Group. There were exclusion criteria similar to GELF. That's the BLNI criteria. It's all arbitrary. Exclusion criteria is from trials run in the 90s. And patients were randomized to watchful waiting versus chlorambucil. Again, no difference in overall survival. So this led us to the backdrop that you can observe some of these patients.
That was a super helpful historical overview, and it really provides important context as we discuss the management for these patients. We don't want to add treatment leading to side effects in a cancer that generally has a favorable prognosis. We also don't want to play our cards too early, since the goal is to maximize that progression-free survival and time to next treatment. So let's get back to our patient with stage 1 disease. What's the data behind radiation for possible curative intent in patients with follicular lymphoma?
So lymphoma is a radiosensitive malignancy, so it's reasonable to surmise that radiation to localized disease might lead to prolonged remissions in follicular lymphoma. There are numerous retrospective studies looking at outcomes of radiation in patients with stage 1 or stage 2 follicular lymphoma, and one of these pivotal studies was published in 2006. This was a retrospective study of 106 patients who underwent radiotherapy for early stage grade 1 to 2 follicular lymphoma. And at 15-year follow-up, about 40% of these patients remained in remission. Keep in mind that it is unclear if the same number of patients would have required treatment with observation based on data from the Stanford cohorts that we had discussed. And we'll link the radiation study and the Stanford observational study in our show notes, so definitely check that out. Bottom line is that we think there is likely a curative fraction of patients with radiation therapy, and so it's reasonable to pursue this with the goal of preventing the need for systemic therapy in the future. Patients should be counseled that if they were observed, they may never need treatment. Modern radiation treatments are often given as 24 gray in total, which would be at 2 gray over 12 fractions, so patients should expect roughly 12 radiation sessions, and you should just know this for when you counsel them. There's clear local control benefit, so you might want to consider radiation if the lymphoma is in a sensitive area, like localized to the spine.
Yeah, and I think all of that's really important, and it's just important to know that localized disease, radiation therapy is really reasonable because it may not be that toxic, and it could prevent systemic therapy in the future. So if that's the goal for the patient, it's reasonable. That being said, maybe half these patients wouldn't have needed treatment anyway. It's not really changing your overall survival, but quality of life is also important, and it just depends on the patient. So it's important to have these discussions and recommend a referral to radiation oncology for our localized stage 1 follicular lymphoma patients. Let's change the case and say that we have the same 75-year-old patient, but now the PET CT shows adenopathy above and below the diaphragm, so we have stage 3 disease. Excisional biopsy is still consistent with classic follicular lymphoma, and she remains asymptomatic. How do we approach these cases? So now we have more adenopathy, so we're not going to radiate. We have this patient asymptomatic. Dan, what are you going to do here?
This is where you can apply the Guelph and BLNI criteria to determine if the patient warrants treatment with combination chemoimmunotherapy, like BR or rituximab and Revlimid, versus observation or rituximab monotherapy. Assuming she did not have a lymph node greater than 7 centimeters or 3 nodes greater than 3 centimeters, she could be observed because she doesn't really have any symptoms or cytopenias. Or we could offer her rituximab monotherapy. Remember that rituximab is an anti-CD20 monoclonal antibody that revolutionized treatment in B-cell lymphomas, significantly improving overall survival. It's a truly targeted option for a lot of patients. After the trials from Guelph and BLNI did not show any benefit for early treatment, there was a subsequent randomized study comparing rituximab monotherapy weekly times 4, followed by rituximab maintenance every 2 months for 2 years, versus rituximab weekly times 4 with no maintenance, versus observation alone. The 15-year follow-up of the study was published in Lancet Hematology just a few months ago as of the time of recording. Patients with asymptomatic stage 2 through 4 follicular lymphoma were included in the trial. The rituximab weekly times 4 group was closed early because of lower accrual and the thought that maintenance should be standard of care in follicular lymphoma. That's the thought the investigators have, and honestly, it was probably premature. There were over 180 patients in the observation group, 80 in the rituximab induction group, and 190 in the rituximab maintenance group. The proportion of patients not needing treatment at 15 years was 65% in the rituximab maintenance group, 50% in the rituximab induction alone group, and 35% in the observation group. Notably, there was no difference in time to second treatment or overall survival. Of the patients who needed treatment in the observation group, the vast majority required chemotherapy with rituximab and not just rituximab monotherapy. So, Aviva, could you tell us a little bit about how you interpret these results?
Yeah, it's really interesting. This gave the bottom line conclusion, if you read the abstract, is essentially that rituximab monotherapy followed by maintenance improved time to next treatment and prevented patients from getting chemotherapy. And here's the complexity of what we're dealing with here. As we're knowing here, this is a good natural history study. At 15 years with advanced follicular lymphoma, 35% of patients never needed treatment. That's a large number of patients that never needed treatment. When we think about this study, the way it was accruing 1 to 1 to 1, I think that made a lot of sense. And when we think for patients, if you're not improving overall survival and you're not changing the trajectory of the disease, the time toxicity of coming into an infusion clinic for rituximab therapy every 2 months for 2 years is a lot. the cost of that therapy is also very high. And I would have hoped to see that rituximab induction group had more patients in it so we could get a better understanding of the long-term gains of that approach as compared to observation. What I will say is, for patients in practice, doing a bunch of maintenance for these low-burden asymptomatic patients doesn't really make a lot of sense because of the availability of very effective therapies in later lines and because of that time toxicity. So rituximab weekly therapy times 4, that induction therapy without maintenance, is extremely reasonable for this patient population if you're going to offer them therapy. And you can counsel them and say, hey, look, works half the time. Half the time, you won't need treatment at 15 years. That being said, if we didn't do anything, over a third of the time, 1 in 3 people would never need treatment anyway. And then it becomes to the patient discussion of what they need. And I think the patients who really would benefit from this are those with, that Ronak had mentioned earlier, if you have symptomatic adenopathy, let's say you had a patient with adenopathy close to the ureter. Maybe that rituximab weekly times 4 makes a lot of sense for that patient if they have diffuse disease and you didn't want to just radiate that spot, or the radiation oncologist said, hey, I don't know if radiating this spot makes a lot of sense. Why don't we give some systemic therapy that spares the patient from chemotherapy? So ultimately, if you go with the watchful waiting approach, the downside is that when you do need treatment, most of these patients are getting chemo. So rituximab weekly times 4 could prevent chemo in some patients, and I think that's reasonable. The time toxicity that you're dealing with every 2 months for 2 years is probably just not worth it for some of these patients.
That's a great point, and I think these are really, really important for reminders for us as we think through patients that we see in clinic. Let's say that our same 75-year-old patient with the excisional biopsy showing classic follicular lymphoma has diffuse adenopathy with the largest node measuring 9 centimeters, and she has significant B symptoms. How would we approach these patients?
For patients with follicular lymphoma, there were historically 3 common regimens in the rituximab era. There was bendamustine rituximab, or BR, R-CHOP, and R-CVP, which was R-CHOP without the anthracycline. In general, BR has much less toxicity than R-CHOP, and there was a push to determine which would be more effective overall for these patients. There were 2 randomized phase 3 trials that demonstrated non-inferiority and possibly superiority of BR over R-CHOP or R-CVP. The STIL study, STIL, was led by a German group and published in 2013. We'll have a link to that in our show notes. And the BRIGHT study was led in the United States and published in 2014. The STIL trial showed improved PFS with BR over R-CHOP, but no difference in overall survival. The BRIGHT study showed similar PFS and OS between BR and investigator choice of R-CHOP versus R-CVP. In both studies, BR was less toxic, and so it became standard of care based on these results. There is one more phase 3 RCT looking at R-squared, which is Revlimid and rituximab, versus investigator's choice of R-CHOP or R-CVP, called beautifully the Relevance trial, which also showed non-inferiority of the less intensive regimen of R-squared, and that was published in NEJM in 2018.
So I just wanted to recap here. So we have our stage 1 localized patients, observation versus definitive radiation therapy for curative intent. Then we have our more advanced stage patients. Maybe they have more adenopathy, but they're asymptomatic. They didn't meet those arbitrary GELF and BLNI criteria. Remember that clinical judgment is key on when to treat. These were exclusion criteria from trials that we had discussed, published in the early 2000s and late 90s. And for those patients, we have observation versus rituximab monotherapy. And then now Dan just described, okay, what if you have a really symptomatic patient with follicular lymphoma? What do you do? And BR beat R-CHOP or RCVP. Pretty easy. But what about this other regimen, this Revlimid rituximab, this R-squared? Really, when we think about that, there's never been a study looking at BR versus R-squared. And the problem with R-squared is, one, it's incredibly expensive. A month of Revlimid is like $20,000. That's super, super expensive when we're talking about giving these patients therapy, and they're on therapy for about 18 months. So it's 18 months of therapy as opposed to 6 months of chemotherapy with BR. The other thing is Revlimid rituximab is approved in the second line, so it's an effective agent in the second line setting for these patients. So it's thinking about the idea of, do we want to play all of our cards up front now? and the cost of these therapies are quite high. So both are approved combinations. For the most part, we're thinking that these patients are getting bendamustine rituximab. And the other thing that I want to point out is that you'll hear a lot of people get bone marrow biopsies. So I just kind of wanted to really talk about bone marrow biopsies right now. So now that we've discussed all of these trials, there is a really good study that was published just a few years ago in the JCO, and they did a pooled analysis of patients from these prospective trials and said, hey, if they got a bone marrow biopsy at the beginning, did it make any difference to their outcomes? Meaning, did it change responses? Did we need to do a bone marrow biopsy at the end? Did having bone marrow involvement change anything for these patients? And it was found that 99% of the time, doing a bone marrow biopsy did not influence management or didn't change anything for the patient. It was over 99% of the time that if a patient responded in their nodes, they also responded in their bone marrow. So knowing that they have it in their bone marrow to begin with is completely unnecessary. It doesn't change your management. So we're really talking about when to do the bone marrow biopsy. It's for, do we want to cure them with radiation? And then number two, if you think you need to treat the patient, the only indication to treat is cytopenias, or you're looking for something like MDS or something else, then you really want to think about doing a bone marrow biopsy. Otherwise, over 99% of the time, it doesn't matter, because when you treat the patient, look at their lymph nodes, it correlates to response in the bone marrow.
Okay, that was really helpful. I'm glad you went over that. Definitely an issue that comes up a lot, I think. And in terms of rituximab maintenance, this is something we mentioned a little earlier on. Was there any further looking at that? You mentioned time toxicity. I feel like that's an important concept. Are we still doing 2 years of maintenance?
So this was a question that was looked at in a trial called the PRIMA trial, and this was giving patients rituximab every 2 months for 2 years. And what they essentially saw was time to next treatment was 50% in those people that got treatment with Rituxan every 2 months versus 40% in patients that did not receive the Rituxan in that arm. So while, time to next treatment certainly favors rituximab, there was no overall survival benefit. So I think this further highlights what Vivek has been alluding to, some of the important factors here. Not only is rituximab not completely a benign medication, but there is this element of time toxicity. And so what this means for clinical practice is, while it may be important to consider offering maintenance therapy to our patients and explaining that there might be a small benefit with regards to time to next treatment if that's even necessary, we don't actually think that this strategy changes the overall survival for our patients. And so incorporating this and all the logistics of getting infusions, et cetera, in that initial discussion, super key to making sure our patients are informed about what their treatment's going to look like.
And Ronak, I think that's really important, because now we have no overall survival benefit for a maintenance rituximab every 2 months for 2 years. And what we do know is the biggest prognostic factor in follicular lymphoma, and we're going to talk about this in our next episode, is if the patient has progression of disease within 24 months. So progression of disease within 2 years of your initial therapy is really the most important prognostic factor for these patients. That occurs in about 20% of patients. Maybe 1 out of 5 patients have that, which means that you're exposing 1 out of 5 patients for unnecessary every 2 months for 2 years. And when you really think about that, it makes you wonder, how much are we really benefiting these patients, particularly with the newer therapies with bispecific antibodies coming down the pipeline, with things like Revlimid rituximab, and the fact that sometimes time to next treatment means radiation or Rituxan monotherapy. All the things that we talked about before apply in the later lines for patients with low burdens of disease. So I think it's important to offer to the patients. Some patients value that, and that's important to talk to them about. Well, some patients might say, hey, if it's not going to make me live any longer, I think I'm good. And I think all of that's reasonable and is very tailored to the patient.
Guys, I think this was a fantastic discussion. I think we went through some really, really important factors, not only for, the history of the disease and how we treat, but also, again, some high-yield facts to remember when you're in clinic. So any final thoughts? I'm really looking forward to the next episode where we continue this discussion for sure.
One thing I want to just leave out on is for those patients with advanced disease, when we talked about the STILL studies and the BRIGHT studies, the CR rate was about 60%. So it's important to keep in mind that the CR rate is 60%, yet the PFS, we're looking at like 50% at 9 years, 10 years. So follicular lymphoma is one of those things that we don't need to get a perfect response. We need to debulk. We can watch these patients, and sometimes this lymphoma grows really slowly, and keep that number in mind, that 60% number in mind, as we see bispecifics move up in the front line, where we're seeing in the early trials 90% CR rates and above. So keep all of this in mind. We're excited to see where the space evolves over the next 5 to 10 years.
All right, guys. So I think that wraps up another fantastic episode of the Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.